Good morning. In this session, at the moment, I'll be discussing a very unusual case. The title of this talk is From Typical Posterior Canal BPPV to Canalith Chaos, Navigating Spontaneous Nystagmus and Canal Switches. The figure you see on your screen is the figure A and B, both left-sided horizontal semicircular canals, as viewed from the rear of a patient who is lying supine. The debris in black dots in figure A is free floating, that is, it can move either ambulopitally. If it moves ambulopitally in the left horizontal semicircular canal, it would result in the excitatory nystagmus towards the same side, horizontal nystagmus beating to the patient's left. And if it moves ampulofugally, there would be ampulofugal deflection of the left horizontal semicircular canal. That would mean a nystagmus which is beating away from the left, that is the right sided horizontal nystagmus. So what happens when the canal jam occurs? Suppose the canal jam occurs when there is a inhibitory ampulofugal deflection of the cupula, which is shown by the black hair. So it will be persistently deflecting ampulofugally because the jam occurred when it was deflecting ampulofugally. It would result in spontaneous, non-persisting, right-beating nystagmus. So it would be a inhibitory type of nystagmus. So why this is important to realize is that what happens is very illustratively shown in this patient. This is a 77-year-old female patient came with the history of positionally triggered disease spells for past 2 days, especially on lateral recumbency and getting out of the bed. The left Dix-Hallpike test after a short latency shows a upbeating left torsional positional nystagmus lasting less than 60 seconds. So there's hardly any doubt about the diagnosis. It is typical periampullary located left posterior semicircular canalolithiasis, which is easily treatable by the Epley maneuver. Indeed, the reversal nystagmus was also present when the patient was uprighted from the left Dix-Hallpike position. You can very well see a nystagmus that is downbeating and right torsional. The reversal nystagmus occurs in 75% patients with posterior canal BPPV of the typical type. So we carried out the left Epley maneuver. Immediately after carrying out the Epley maneuver, we were trying to do a positional retest to confirm that whether we have successfully repositioned the autoconal debris into the utricular macula. But as we applied the Frenzel glasses, we observed a spontaneous nystagmus which was right beating, as you can see on your screen. So if this is a right beating nystagmus, it means that the Canalith jam has occurred. And how the horizontal semicircular Canalith jam has occurred? There was an initial canal switch from left posterior semicircular canal. What did we do? We did a head shaking maneuver, side to side, with the neck antiflexed around 30 degrees. Let us see what happens to the nystagmus. The nystagmus then becomes left beating. So it implies that we have successfully unclogged the left horizontal semicircular canal. Now the autoconal debris is free floating and is deflecting the cupula of left horizontal semicircular canal ambulopitally. That's reflected by the left beating horizontal nystagmus, which you can see on your screen. So what to do next? The next thing to be done was a supine roll test. How the head shaking helps? The inertial forces which are generated during the head shaking, they break up the autoconal debris, and that's why you saw a ampuloputal cupular deflection, and which was reflected as left beating nystagmus, which was initially right beating after the Epley maneuver. We did a supine roll test. The supine roll test elicited A lying down nystagmus to the right as the patient is positioned from long sitting to supine with head straight ahead. On head yaw to left, it elicits a geotropic strong positional nystagmus which is horizontal. The quick component of the nystagmus is beating towards the lowermost left ear in the left lateral head roll. So if it is geotropic on the left, it has to be geotropic on the right. The stronger of the two will decide which is this side involved, that is the lateralization. Here the nystagmus is much weaker as compared to left lateral head roll, and taking the two things together, the direction of the lying down nystagmus which beats towards the contralateral ear, that was right side in this case, and the stronger geotropic horizontal positional nystagmus during the left lateral head roll, we took this as left-sided horizontal semicircular canal BPPV because of the canalolithiasis involving its long posterior non-ampullary arm. That is the non-ampullary arm of the left horizontal semicircular canal. So what next to be done? We performed a Gufoni maneuver. Patient from short sitting was shifted to right lateral recumbent non-involved side for 1 minute. After 1 minute, the head was inclined 45 degrees to her right, that is with nose directed towards the mattress of the examination couch. To make the patient feel comfortable, we remove the myofrenzial glasses. And here in the position 2 of the Gufoni, which you are seeing right now, she was maintained in for around 2 minutes, after which we uprighted the patient, completing a single Gufoni maneuver. Making it fast forward. So after 2 minutes in the position 2 of the Gufoni maneuver, the patient was uprighted. No spontaneous nystagmus was seen after 24 hours. We looked for the spontaneous nystagmus for around 30 seconds and none was seen. Initially, after the first cleft Epley maneuver, we saw a nystagmus which was right beating, which after the therapeutic head shaking to relieve the Canalith jam in the left horizontal semicircular canal became left beating. So we hadn't done the left Dix-Hallpike retest after the first Epley maneuver because we saw a horizontal nystagmus. So we did a left Dix-Hallpike retest first at 24 hours, and we were surprised that patient elicited a downbeat nystagmus with a right torsional component. The upper corneal poles of the both eyes were torsionally beating to the patient's right. This nystagmus was quite persistent, lasting over a minute, and this is not typical crescendo decrescendo. So such a nystagmus is called slow crescendo decrescendo or simulparoxysmal nystagmus, and this is characteristic of apogeotropic posterior canal BPPV. The direction of torsion is towards the non-involved right side, so it is a re-switch of the otoconal debris. First, there was a typical periampullary posterior semicircular canalolithiasis. We treated with the Epley maneuver. There was a immediate canal switch and a canal jam. The canal jam was taken care by the head checking maneuver. Thereafter, we saw a geotropization of the nystagmus with the geotropic horizontal semicircular canal BPPV being treated with the Gufoni maneuver. And now we have a re-switch. The particles from the left horizontal semicircular canal have switched to the, after the treatment of with the Gufoni maneuver, has switched to the non-ampullary arm of the left posterior semicircular canal. So what did we do? We carried out a demi-Semont maneuver with mastoid oscillations. That is mastoid oscillation augmented demi-Semont maneuver. From short sitting, the head was rotated 45 degree to her non-involved right side, briskly taken to the right little recumbent with nose down, and the mastoid oscillations were applied. Mastoid oscillations are to be applied for 15 to 20 seconds at one time, and then we should wait in the demi-Semont position for some time before applying it another time, but not more than 15 to 30 seconds at one time. Why? Because there are two things. Number one, if the otoconal debris is jammed partially in the non-ampullary arm, we need a time for the jam to unclog. So that is important for the vibrations, the mastoid oscillations being done. But if we keep on the mastoid oscillator on the mastoid bone, what will happen that once these unclogging has occurred, the otoconal debris will keep moving in the utricle without getting embedded into the utricular macula. So a release position is important to be maintained in this case. And secondly, if we keep long periods of mastoid oscillations, then there is a possibility of inducing a BPPV by the release of otoconal debris from the utricular macula into other canals. That is, you are going to induce it, and this is common after the dental treatment of the root canal. We get a lot of patients with BPPV. So after that, what to do next? We did a 45-degree forced prolonged positioning. This is the 45-degree forced prolonged positioning in this patient. To the right, that is the non-involved side, the head is not completely on the pillow. It is half on the pillow and half on the mattress of the bed, so that the head is rotated 45 degrees to the patient's right. This was maintained for 1 hour. The recommendations as per the article of the Paolo Vanucci 2015 is 8 hours of this position, that is 45 degree forced prolonged positioning to the non-involved side. But practically it becomes difficult. We examined the patient with a second Dix-Hallpike test after 4 hours, and there was no positional nystagmus that was earlier seen. The eyes are totally static. In the previous, that is the first left Dix-Hallpike retest, there was a downbeat and right torsional positional nystagmus of slow crescendo decrescendo type, suggesting a canal re-switch from horizontal canal of left side to the non-ampullary arm of the left posterior semicircular canal. Patient was asymptomatic, and she continues to be asymptomatic after 9 months. So final diagnosis is left posterior semicircular canalolithiasis, typical periampullary garden variety of the posterior canal BPPV. Treatment related complications. Number 1, canal switch to the left horizontal semicircular canal with immediate Canalith jam. Secondly, canal re-switch to the non-ampullary arm of the left posterior semicircular canal. So that was treated with the demi-Semont maneuver and the mastoid oscillations and force prolonged positioning.